Okay, so we're ready to start. Hello, everyone. Welcome to another session of Surgical Fix. Today's session will be on diabetic foot. My name is Ali Khayat. Welcome. Just a reminder over how the session will go. Our sessions are interactive. We have our regular questions in the beginning and the end of the session, where you will be able to answer them in the poll. And you can answer any questions regarding the session in the Q&A panel, and we'll answer them in the dedicated time at the end of the session. Also, a reminder of our, you can register to our next Surgical Fix session in the link in the chat. And we have our oral mock exam series every Saturday that is targeted towards the R5 general surgery to prepare them for their final exam. Who are the R3 and the R4 are welcome to join and observe. Also, we have our survey to help us improve our performance and deliver more courses in the future. The link is also available in the chat. If you could please take a 5 minutes of your time to help to fill the survey. And now, without further ado, I would like to introduce Dr. Munira Al-Nakhi, our guest speaker for today. She's a consultant plastic and reconstructive surgeon. She specializes in reconstructive microsurgery and super microsurgery. She's also took her plastic and microsurgery fellowship in Korea at the Asian Medical Center. She's also a fellow of American College of Surgeons, and she's a member of many multiple societies, such as the World Society of the Reconstructive Microsurgery, and a member of the American Society for Reconstructive Microsurgery. She's also an executive member of the Women Surgeons of Kuwait Committee. She's also an active researcher and an invited international speaker to multiple conferences around the world. Welcome, Dr. Munira. The floor is yours.
Thank you, Dr. Ali. Good evening, everybody. I would like to thank all the organizing committee of the Surg Q8 for the kind invitation. And I'm very happy to be presenting my second topic in that nice program course. Unfortunately, due to some technical errors on my side, my presentation will be a simple PowerPoint, not the usual RISD presentation. However, I hope I can provide you later on with the original RISD presentation, the usual. So at the beginning, we'll just put the questions as advised. So MCQ number 1, which of the following is correct regarding diabetic foot ulcers in diabetic patients? A, lifetime risk for diabetic foot ulcer is 50 to 70%. B, recurrence rates for another diabetic foot ulcer in 5 years is up to 25%. Risk of some form of amputation is about 40%. No association was found between 5-year mortality and amputation in diabetic foot ulcers. Amputation in diabetic foot ulcer can be prevented in up to 85% of the cases.
As usual, we'll give them 1 minute per question. We'll have 20 seconds left. Time is up.
Okay. Second question, 75 years old patient who presented to you with a plantar ulcer with exposed head of first metatarsal bone and abscess collection. All of the following is correct, except most probably the etiology is ischemic ulcer, or his correct Wagner classification is grade 3. University of Texas, PEDIS, and SIMBAD are additional classification systems can be used. Most probably the etiology is neuropathic. Offloading using either total contact cast or removal air pod is needed. So which one is incorrect?
20 seconds left. And time is up.
Okay. Third question, in regard to assessment of diabetic foot ulcer patient, which of the following is correct? A, the monofilament test should be done for all 8 sites to be able to identify 90% of patients with peripheral neuropathy. B, transcutaneous oxygen is superior to ABI in predicting wound healing potential and the degree of small vessel disease. ABI of more of 1 exclude peripheral vascular disease in diabetic patients. Palpation of peripheral pulses has no role in assessment of vascular status in diabetic foot ulcer. Critical limb ischemia is diagnosed when ABI is less than 0.6.
Ten seconds left. Final few seconds. Time is up.
Fourth question, all of the following are considered a recommended type of wound debridement in diabetic foot ulcer except hydrosurgery, autolytic, biological, surgical, wet to dry.
I have 30 seconds left. Of course, these questions, we'll discuss them at the end of the session and we'll go through their answers. Ten seconds left. And on to the final question.
Last question, a 64-year-old patient with long-standing uncontrolled diabetes, hypertension, and ischemic heart disease. He presented to your clinic with 4 months history of heel ulcer. On examination, there is 8x6 deep ulcer with necrotic slough. Probing test was negative and no evidence of cellulitis or collection. Both dorsalis pedis and posterior tibial artery pulses were felt. What is your next step? First option is CT angio is needed first before any action or debridement. B, admission is needed with swab culture and start of IV antibiotics. Third option, dressing and hyperbaric oxygen chamber to improve the healing. D, sharp debridement, regular frequent dressings with close follow-up, offloading and vascular lab study to prepare him for wound coverage. Last option, prepare him for below knee amputation as heal, never heal.
30 seconds left. Last few seconds. And time's up. Okay, so we're done with the first MCQ. So on to the slides.
Yes, today's talk is going to be about diabetic foot and diabetic foot ulcers. The whole idea of this talk is to make you well educated and how to manage those cases. So we want to prevent the amputation of diabetic foot patient limbs. 1 hour is not very enough to cover the whole subject of diabetic foot. In fact, I need a whole day to talk about the different aspects of diabetic foot. However, I try to give you the most important clinical oriented information that will help you in your clinical daily life. So basically, first we're going to start an overview definition of the problem with diabetic foot, why we are learning about it, the etiology, the causes of diabetic foot, and how a diabetic foot ulcer will develop, the pathophysiology. Then we go to classification system of the diabetic foot ulcers, what is special in Gulf region, assessment and examination. We'll talk about diabetic foot infection regarding soft tissue and bone infection. We'll talk about Charcot foot, and then we talk about how do we manage diabetic foot ulcers, and we emphasis on the limb salvage versus amputation theory. Then the favorite part of mine is reconstruction of diabetic foot, and lastly we talk about some new innovation in the field of diabetic foot. Well, let's start. As you know, diabetes is one of the major public health challenges. It affects more than 460 million adults worldwide. According to the International Diabetic Federation, the last edition, the 9th edition, 2019, it's estimated to affect 700 million people by the year of 2045. This is the map of the world. And as you can see, the trend of type 2 diabetes is increasing all over the countries. However, unfortunately, in our region, MENA region, the Middle East and North, it has the highest increase, up to 100% increase in the coming few years, 25 years only. When we do the prevalence, age-adjusted prevalence in MENA region, we can see the highest prevalence is more than 9%, which is very high. And unfortunately, our country and most of the Gulf countries and some of the North Africa countries have this high incidence of diabetes. And when we see in matter of franc, you can see from the Gulf country, Bahrain is number 3rd, Kuwait has the 8th position in the MENA region of the number of cases of type 2 diabetes. Unfortunately, it's not only type 2, even type 1 diabetes in children in the whole world. And our country has the incidence rate of 41.7%, the 3rd on the world. It was around 35 3 years ago, and we were number 1 in the world, unfortunately. So what is diabetic foot? It is a complex, chronic, serious complication of patients having diabetes. According to the WHO, it is an ulceration of the foot which is associated with neuropathy and different grades of ischemia and infection. It has a major long-term impact on the morbidity, mortality, and also the quality of life of the diabetic patient. Lifetime risk, that means a diabetic patient to have some sort of ulcer in his foot is between 15 to 25%. However, a patient who has an ulcer, he has a chance of up to 70% recurrent ulcer for the 5 years of the start of their first ulcer. In US, usually nearly 2 million Americans has diabetic foot ulcer every year. And with the 5 years of ulceration, 5% of those patients will undergo major amputation, and of those, 70% will die. So, the patient with diabetes who develops an ulcer, who develops a diabetic foot, he has a greater risk of premature death, MI, and fatal stroke. Also, he has high risk of hospitalization and resource utilization, and it's equivalent to other major chronic diseases such as heart disease, stroke, or cancer. So diabetic foot is as equal as a cancer in cases of resource utilization and mortality. This is what we want to prevent. We don't want to see any more diabetic patients coming to you in this picture. Why? Because diabetic foot ulcer lead to some sort of amputation, either minor or major amputation, in 20%. And unfortunately, every 30 seconds, a lower limb is being amputated somewhere in the world just because of diabetes. It is estimated from several studies that these amputations can be prevented in 85% of the cases. How? If we have improved foot care programs, if we do have early diagnosis, if we have prevention programs, and if we do effective treatment. So the whole idea of this lecture for you to be very strong in diagnosing diabetic foot ulcer and to implement a prevention program and early intervention just to avoid amputation. Just to let you know how serious it is, a new onset of diabetes, an ulceration is reported. 5-year mortality with a patient with having ulcer is up to 55%. And if that same patient has an amputation, his mortality rate in 5 years will be 75%. Etiology? Well, everybody knows that before diabetes, there is a status called pre-diabetes, where the patient has some sort of impaired glucose level, impaired glucose tolerance, the whole picture of metabolic syndrome. Here, where we have the weight reduction with the nutrition, the help of bariatric surgery, just to avoid the transformation of the pre-diabetes status into fully blown diabetes. Diabetes is known that it has pathy affecting several organs. The most important that we deal with in the diabetic foot is the diabetic neuropathy, whether it's sensory, motor, or autonomic, peripheral vasculopathy, and other from retinopathy, CNS, and renal, kidney nephropathy. I'll choose this picture or this diagram to make you just a little bit easy in understanding. And as we said, how does a motor neuropathy in diabetes predispose to diabetic foot? Sorry. So when you have a motor neuropathy, you will have a deformity in the foot. So you're going to have a biomechanical abnormality. So the patient, when he walks, he doesn't walk in the normal weight distribution. I'll explain that later. There is sensory neuropathy, so he doesn't feel. So there is loss of protective sensation. He will walk on hot area, he will not feel, he will have burn, he will have a trauma, injury, foreign body, he will not know. Another part of the neuropathy is the autonomic. He has decreased sweating, so his skin is dry, so it cracks easily, and you know the crack and fissures will cause a port of infection and entry of the organisms. Also, we have vascular changes in the endothelial cell dysfunction causing vasoconstriction, so it makes the blood supply less. We have immune changes secondary to diabetes with increased T lymphocyte apoptosis, which will inhibit the healing, together with repeated trauma, together with the already present peripheral vascular disease. Patient will have a subcutaneous hemorrhage. If this is neglected, the same causes are there. He will have a foot ulcer. If that ulcer get infected because no immunity, then it will have more infection, abscess, and osteomyelitis. So this is the pathophysiology of how a diabetic foot ulcer develops. We don't want this. This is just a few pictures of my own patient referrals that I receive daily over the last 5 years. They're horrible cases. We are trying to prevent reaching to this status. We want to prevent this from occurring from the start. So what's the classification? Classification is basically 3 types: neuropathic, ischemic, or a mixture of both. So if we talk about the neuropathic, usually we said there is no sensation, so the ulcer will be painless. A big difference with the ischemic. So if you have a patient with an ulcer, you examine, he shouted when you palpate the ulcer, it means most probably it's ischemic. Callus presentation is usually present in neuropathic ulcers. However, in the ischemic ulcers, you're gonna have gangrene. The wound bed in neuropathic ulcer will be pink and granulating. However, you will find it surrounded by callus. I will show you some pictures now. Ischemic ulcer, usually the bed is pale with slough and poor granulation. Since the neuropathic, the blood supply is okay, the foot will be warm, the pulses will be felt, and the ischemic is gonna be cool with absent pulses. We said the dry skin because of the autonomic neuropathy. The ischemic ulcer will have delayed healing. The typical location of the ulcers in the neuropathic ulcer is going to be the weight-bearing areas, usually the metatarsal heads. And if he has claw toes, you will have the dorsum of the claw toes. In the ischemic, usually it's in the distal areas, tip of toes, nail edges, between the toes, and lateral border of the foot. Neuroischemic is the most common type we see it, then followed by neuropathic. Neuroischemic is a little bit difficult because it's a mixture of both types of ulcers. This is what I mean by neuropathic ulcer. Pressure point, head of the first metatarsal bone, clear callus around it, red, granulating, healthy looking ulcer. So this is neuropathic diabetic foot ulcer. This is ischemic ulcer. Tip of the toes, gangrene. You can see the bed of the wound is slough, unhealthy, no granulation, and you can see also the changes of the nails. Neuroischemic is a mixture of both. Gangrene, callus, mixture of both. There are certain wound classification systems available. The most four important ones are Wagner, University of Texas by Armstrong, Pedis, and Simbad. Why do we need to have a wound classification system? Well, so we'll have a universal language. When I communicate with another doctor in another department, in another hospital, other center, another country, I can convey the message, how serious is the diabetic foot ulcer, by saying a universal language. The most easy one and commonly used is the Wagner classification. Well, if you don't have any wound and you have only deformity or cellulitis, it's grade 0. When we start to have superficial wound, whether partial or full thickness, it's grade 1. When the ulcer is deep and reaching deeper structures such as the ligament, joint capsule, tendons, however, there is no infection, no osteomyelitis, no abscess, it's grade 2. Whenever abscess occurs on these deep ulcers with either osteomyelitis or sepsis in the joints, it's grade 3. Grade 4, when you have a localized area of gangrene. Grade 5, when the gangrene is extensive, involving the entire foot. So now when I tell you by phone, I have a patient with grade 3 Wagner ulcer, then you will know this patient has osteomyelitis, has deep wound, he needs more care than grade 0. Why this foot is sad? This is a foot status in our Gulf country. Why? Because not only we have the habits of uncontrolled blood sugar and no healthy lifestyle, we have other things that we have it by our environment and culture that makes us more prone to have more diabetic foot ulcers. We have more complicated diabetic foot ulcers. First thing to be blamed is our climate. We are desert, so it's hot, dry climate, so easy you can see dry, cracked skin with fissures in their heel and in their foot. The type of the footwear. Usually we wear traditionally the open sandals, and a lot of people still walk at home barefoot. Then we have other cultural and religious practice. We wash the foot too much. We are too much about cleaning the foot. We pray 5 times, so we do wudu, washing the foot 5 times, so they're always between the rib spaces. That's wet, it's not dry. And then still a lot of people, the old people, believe in the traditional medicine, and they use the herbal medicine over their early ulcers, and they come presented late with infected, such as they use the khawajawa, they use the murra, they put even the henna inside the wounds, and we saw horrible cases. Awareness, there is still lack of awareness about diabetic foot problems and prevention, not only between the patient, also a few of healthcare givers are having, and the resources of the healthcare varies from center to center, from polyclinic to hospital. And also there is lack of multidisciplinary team, and this is in the whole Gulf, not only in Kuwait. When we do assessment of the diabetic foot, is very important. It is a team. It's a multidisciplinary team approach. And studies found that doing with a team approach, you have much more improved outcome. You have less major amputation, not mean amputation, just major amputation in 94% of the studies. Always you have to know that you're dealing with a diabetic patient. Diabetes is a chronic systemic disease. You treat the patient as a whole. You assess the patient as a whole. Don't look only at his foot and forget the remaining of the patient. So these are the principles of diabetic foot assessment. Recently, it's been more toward interdisciplinary rather than multidisciplinary. What's the difference? Multidisciplinary is what's going on here in our country, is that I refer the patient, I saw him in my clinic, I refer him to the vascular clinic, vascular refer him to the endocrine, and the patient has to go to the referring cycle. However, it is found now, team approach in the same clinic, there should be at least a wound care team, vascular surgeon, foot and ankle surgeon, plastic surgeon, specialist in infection disease, the maestro endocrinology, and the prosthetic or the one who do the shoe wear should be there, should be see what we want to do for the, also the podiatrist. However, podiatrist is not really available in our GCC countries. So initial assessment, again, diabetes management, blood sugar control should be good glycemic control. We have to take history. I'll take you now about the detail of the history, what we will ask about, and signs and symptoms and all of that. It's very important to consider the socio-economic circumstances and whether the patient has flexible joint. He can see, does he can inspect his wounds or no? Is he well-oriented or no? The new way of assessing diabetic foot, it's called the 3-minute diabetic foot exam. It's a universal technique, it's a fast technique, it's a very easy, it can be done in the polyclinic, in any simple medical center, and it's component of three minutes, each minute for taking, 1 minute for taking history, 1 for performing physical examination, and at the end, education, which is a very important education. It's a standard approach, can be used worldwide. So in the first minute of the examination, you ask the patient, did he have a surgery before on his foot? Did he have ulcer or amputation? Did he do any angioplasty, stenting, or bypass surgery? Did he have any wound that took 3 weeks or more to heal? Is he smoking? And how good control is his diabetes? And then, does he have any burning or tingling of the legs or the feet? Does he have any pain with walking that relieves with the rest, intermittent claudication? Does he have any change of skin, any change of the sensation? And does he follow anyone? Does he see his foot regularly? The second minute, you look for things by examination. Dermatological examination is very important. You see, does the patient have discolored or ingrowing nails? Does he have any fungal infection? You have to inspect between the interdigital for maceration, for the fungal infection. Does he have callus or corns in his foot? Does he have open wounds or fissures? Neurological examination, I will tell you the monofilament test in 1 minute from now. Musculoskeletal, does he have full range of movement of his joint? Does he have any obvious deformity? And then vascular examination by inspection. What about the hair distribution? Is the hair distribution is less in his lower leg, indicating that he has a chronic vascular disease? Does the pulses palpable? Very important, dorsalis pedis and posterior tibial. Do you feel them? And any difference between the temperature between the calf and the feet and between right and left side? What to teach? We finish from the history and examination. Then you have to recommend the patient himself or the caregiving, the one with him at home. He has to visually examine his foot daily, the sole and between the toes. If he can look nicely, but he cannot flex his need to watch, to inspect his foot, he can put a mirror and see through, or he can take help of anyone with him in the house. Always to keep his foot dry after all the washing. Regular changes of shoes. The shoe should be changed every year. He should wear socks, avoid walking barefoot, and then he has to report any lesions. Very important about the shoes, most of the diabetic patients don't know what shoes to wear. So we have to educate them to wear even shoes when they're at home, and they have to change their shoes every year. And then they have to have a specialist recommendation. They shouldn't wear small shoes, is not good, tight shoes or big shoes, even because big shoes, if he moves, there is rubbing friction, it can cause friction burn and wounds. And if the patient is a smoker, you have to advise him to stop smoking, and then very importantly, to have a good glycemic control. So when we examine this, the foot, we have to look at the pressure areas in cases of the neuropathic ulcers, and then we have to see any deformity. If you have flat foot, claw toes, or the interdigital pressure. There is some signs of a high plantar pressure and presentation the patient will have that you have to inspect just before the patient developing ulcer. So you can see which patient is at risk of developing ulcer to do prophylactic measures for him. So as we said, the high arch foot, the claw, lesser toes, if you have muscle wasting in the plantar arch or the dorsum, they call it hollow out appearance, the metatarsal shaft. If he has any gait changes, for example, slapping on the ground, if he has any deformities, or if you have a fatty pad depletion. This is a very nice technology, a pad connected to a computer that can measure how the foot pressure is distributed in the plantar of the foot. So normally the weight is distributed over the heel, head of the metatarsals, and the high arch you see no heel. The red one is the high pressure, all the pressure is over the head of the metatarsals. So this is the normal distribution for the pressure distribution of the weight, so maximum in the red areas. And you can easily see in the diabetic patient, he has different other red distribution, and sometimes it's sparing also the big toe. So let's go for the neurological sensation examination I told you. We have two ways, either the tuning fork, the standard tuning fork, or the 10-gram monofilament test. The test is positive when the patient is not feeling. So if he's feeling, it's not negative, it's the opposite. So positive test means patient have neuropathy, he is not feeling. And it's very important you don't test the neuropathy in the areas of the callus regions. Either you have the fully thing if you are a professional neurologist, or this is just enough. There is disposable, the monofilament disposable, and you have also a lot of these that you can keep it in your pocket. The examination should be done in a quiet place. The patient should close his eyes while you're examining. He should be supine, leveled feet. And then very important to know, if you use the monofilament test for 10 patients one day, then you have to rest the monofilament for 24 hours. Otherwise, the test will be not accurate. I'm going to show you easy way. We have the 4 main red areas that if you examine for, it will identify 90% of patients who are having abnormal monofilament test and peripheral neuropathy. So basically, it's the head of the first toe, head of first metatarsal, 3rd and 5th. You have other green areas which you can do them if you want. However, the main ones are these 4. Since your examination is 1 minute, you don't want to lose the time. You place the monofilament perpendicular to the skin, and then you apply a pressure until you bend the filament, and then you release for 1 second. It's very important you have first to tell the patient on the inner side of the arm, let him feel the test, how it feels, and then tell him close your eyes, and then you do on the 4 areas and ask the patient, and the patient will say, and he say, I feel, you feel where? He should be specific. Is it right or left? Is it big toe or 5th? Like that. Then we have the other part that we have to examine is the vascular status. Palpation of dorsalis pedis and posterior tibial artery pulses are very important. Everybody should know how to examine, even if the patient came without any ulcer. This is as a prophylactic. You have to examine whether you feel it or not, and you have to know it by heart. Believe it or not, it was my final 5th year exam by external examiner. He just asked me, palpate the patient pulses. And he was very happy when I went from the first time I palpate, and he said, you know, you are the first one from all the candidates who would know where to examine from the first time. So this is very important. Then we have other modalities that we can use. I'm going to show you now one by one. You can have the hand Doppler. If you don't feel it, then you can listen. If you can listen for the waves or no. The famous test I am sure everybody knows is the ABI, where you do the ankle brachial. You measure the systolic pressure and you divide by each other. And if you have more than 1.4, it means that it's non-conclusive because the blood vessels are calcified, are not conclusive. And it happens with diabetic. They have medial calcinosis. Sometimes they have high levels, but they are having vascular problems. From 1 to 1.4 is usually, it's normal. 0.9 is borderline. Less than 9 is abnormal and is diagnostic of peripheral artery disease. You need to refer to a vascular specialist. And then below 4, it's critical limb ischemia. More accurately, quick and portable bedside test is called toe pressure. It's less affected by the medial sclerosis that happens with the diabetic foot arteries, so it's more sensitive. And usually, if it's more than 30, it's sensitive, however, not specific prediction for the healing of the ulcer. But if you have an ulcer, you want to see if it's will heal or no. If it's more than 30, then it's good. This is a normal vascular study lab that you can see. You can see the waves are tribasic waves, and you can see the ankle brachial index is 1.08, 1.6. So this is a normal study. This is a patient with ABI 0.85 and 0.67, left side more disease. You can see the waves are biphasic. This is another case of diabetic also with the ABI 0.6 and 0.5, and you can see the small vessels have more disease, the distal vessels more disease. And this is unfortunately a case of critical limb ischemia where it's 0 below knee on the right side and 0.4 only, and you can see even there is no waves or monophasic waves. The more recent and more sensitive the transcutaneous oxygen measurement. This is the probe of the case, the patient, if he has ulcers, it's a non-invasive, it measures the local oxygen perfusion in the skin. So you can know the status of the wound and you can predict the wound healing potential. And also it helps identifying how bad is the small vessel is involved. And also it determines accurately the amputation level. If you have a patient with ABI of critical ischemia or gangrene, then by putting this, you know where is the level that you can save the limb and where is the amputation level will be. And also it will monitor the efficiency of the ongoing therapy, especially I can use it to indicate which patient can go to the hyperbaric oxygen chamber. I will mention that later on. So this is a table. If it's 70 to 50 is normal. If we have less than 40, this patient will have impaired wound healing. Less than 30 is critical limb ischemia. So after we said all of that, there is certain risk classification that will give you which patient needs a closer follow-up every month or who needs 1 yearly follow-up and how fast you need to refer the patient to the specialized care. So a very low category when the patient has no peripheral neuropathy or peripheral artery disease and he is diabetic for a long time. This one you can see and inspect his foot every year and you can refer him to a specialist in 3 years. 3 months, sorry. A low risk category, well, they have a long-standing deformities. However, they don't have still any ulcers. You can see him into 4 months period and refer him to the specialized center within 1 month. Moderate risk, if you have peripheral vascular disease, absent or diminished pulses, and he has swelling and edema, this should be seen every 2 months. And then the high-risk patient who have a previous history of ulcer, or if he has previous history of amputation or any change in the skin or temperature, he should be next available outpatient referral. And the one with ulcer or sign of infection should be immediately referred and need hospital admission. Now we'll talk about diabetic foot infection, both soft tissue, and then I'll talk to you about osteomyelitis. Around 50% of all diabetic foot ulcers will become infected. And out of these infected ones, 20% will need amputation. The guidelines recommended that we diagnose on the basis of 2 or more of the following. If we have local swelling or induration, erythema, local tenderness or pain, local worm, or permanent discharge. However, because of the neuropathy and peripheral vascular disease, Those may blunt or mask the signs of typical infection in the diabetic foot patient. We call it subtle signs. So up to 50%, unfortunately, will not present classically to you with infection. However, you have to be very careful. You have to look for increasing exudate. If you have friable granulation tissue, not any red granulation tissue is good. Sometimes it's red and it's easily taking apart and bleeding is not good. If there is undermining under the wound edges, and if there is a bad odor. What are the signs of spreading infection? Alarming sign, that means the patient really needs intervention and admission, is spreading or intense erythema, increasing in duration, lymphangitis, regional lymphadenitis, or the patient present with you with typical signs of septic shock, hypotension, tachypnea, tachycardia, or is even having Rikers. So, what are the risk factors? Which ulcers that will let you know that this patient will develop infection? High prone for infection, you have to act by doing antiseptic techniques and follow him or more closely. If you probe the ulcer and then you hit the bone, it's called positive probe to bone test. If the ulcer is there for more than 1 month, if the patient gave you history of previous recurrent ulcers, if patient had a trauma, because usually trauma is a not clean wound, if the patient has decommented peripheral artery disease, chronic peripheral artery disease, if the patient has previous lower extremity amputation in the other limb, if the patient have neuropathy, he's not feeling, and if he has renal insufficiency and giving the history of walking barefoot. So these are risk factors for a diabetic ulcer to get infected. You have to know that diabetes is a special condition and it affects the foot of their patient. They usually halt in the first stage of wound healing. They will be chronically arrested in the inflammatory phase. That's why they take a long time to heal their wound. And also you have to know that the necrotic tissue and the foreign body in diabetic foot, more percentage, they have impaired the cellular function and they will have that something called biofilm. Biofilm is very important to prevent and very important to treat in diabetic foot patients. What is biofilm? As I told you, it's microorganisms embedded in the matrix of molecular molecules, including proteins and DNA. They might exist on the surface and you can see, however, they might be deeper in the tissue, they might be the whole layer, they might be in patches or islands, they sometimes are not visible, and you have to carefully differentiate between it and between the slough. This is a slough, not biofilm. This is a biofilm. Sometimes you cannot see biofilm. However, you can inspect when the wound is not healing that there is biofilm. There is something called Wi-Fi system. It's not internet. I'm having internet problems today. Spoiled my presentation. It's a Wi-Fi. The Society of Vascular Surgeon for the Lower Extremity Guideline Committee in 2014, they made a system to classify and grading each ulcer so you can anticipate what is the risk of amputation in 1 year. And basically they have 3 components regarding the wound, ischemia, foot infection. That's why the Wi-Fi. So Wi-Fi in the wound, we have 0, 1, 2, 3, no ulcer, small, deep, extensive with gangrene, number 3. If there is ischemia, no, regarding, depending on the toe pressure, as we said, the measurement or the transoxygen saturation. And then if there is any foot infection or no. So no infection is 0. If you have less than 2 centimeters of cellulitis is mild, more than 2 centimeters is moderate, number 2, and severe with sepsis is number 3. Stages is according 1, 2, 3. I will show you how to calculate. There is a special table to calculate. And then it gives you, if a patient is a stage 5, you cannot salvage his foot. This case is for amputation. So this is the table. When you have your numbers, then you can see ischemia, wound, inflammation, and then you see where you go in, which color, moderate, and you know which is your risk for the amputation. There is a lot of consensus, international and local consensuses. Every year we gather, we discuss what's new, we try to put protocols and criteria to prevent the infection in diabetic foot, and what is the modalities to treat. And I was part of that consensus with the big names in the diabetic foot specialty, like David Armstrong, Larvi, JP Hong, Najafi, Khafiar, and a lot of people, Stephen Wu. They're all big names in diabetic foot, and we sit together and they do the international, and we give them in the Gulf region what we have. So basically, when we're managing the infected foot, we need to do these things. We have some certain things in the local wound. We need to treat the infection. We need to have offloading. Then we have to monitor the wound and the ulcer, how it's progressing, and we have to document all of that. So the standard local consists of debridement and cleaning, and then we have to use the exudate level by certain type of dressings. We'll treat the infection, and then we do the offloading. I'll explain all of these now, and then we said the reassessment and 4 weeks basis. Routine cleaning, we have always to wash using either water or saline, any debris, any slough, any tissue for the foot. You don't soak the foot. It's big no for a diabetic foot ulcer to soak it. You just clean, you just wash. And if it's infected, then you can use antiseptic, or if there is high risk of infection, as we said before, we use the antiseptic. Regular debridement, you have to remove the slough, non-viable tissue. Callus, I see a lot of patients with diabetes, you see the white callus, everybody is leaving, is very dangerous. You have to remove it to inspect any ulcers below, and it will cause more ulcers and prevent the healing. A general important idea, if the case you're dealing with is an ischemic ulcer in a diabetic foot, you should first revascularize. You don't do debridement, because whatever debridement you'll do, there is not enough of blood supply. You will have more and more and more of gangrene and necrosis. However, if the patient presented with severe systemic shock and systemic infection, you have to drain that infection. You lay open, you open the abscess, you open all the spaces, and then you do the revascularization, because if you don't interfere, the patient will die from sepsis. So clear the infection without debridement, and then revascularize the case. So why we do debridement? We remove necrotic tissues, we reduce the pressure, we will have inspection of the underlying tissues, we will drain the pus and secretion, and then it will be ready for the topical dressings to work. And by doing debridement, you initiate the trauma and you do the wound healing process, you start the cascade again. And this is always the message I want you to know as a surgeon or as any caring, giving care for diabetic. Debridement is a very important. If you leave the necrotic tissue will cause more necrosis and more infection. There's several types of debridement. There is the non-selective debridement, mechanical. The old, when I was at your age, they were teaching us to do wet to dry. Put a wet gauze, leave it to dry, after 2-3 days, remove. It's a big no, because it doesn't differentiate. It will take all the healthy and non-healthy tissue. It will cause bleeding. It will cause sometimes pain. There are new things I will show you in a few slides of DebriSoft, new technologies, if you want to do it, if you are not a surgeon. However, the gold standard is the sharp debridement using knife and scissors, or surgical new modalities like the ultrasonic and hydrosurgical. There is the enzymatic, there is the autolytic. You use the patient's own secretions, and the idea when you use the hydrocolloid and hydrogel. And there is the biological, the maggot debridement. You put a worm to eat the wound. So this is a DebriSoft. It's like a gloves or like a brush. It's made in a certain fibers that it can gently clean and take the necrotic tissue. There is the gold standard knife and scissor, and there is the newer modality, such as this modality is a hydrosurgery. It selectively removes with a flush of high impulse of water the necrotic tissue, keeping the healthy tissue untouched, and there is a special suction that it will irrigate and suck together the water and the necrotic tissue. This is the enzymatic. Even the honey is considered one of the enzymatic. This is if the patient is not admitted and he's doing it at home dressing. And this is the maggot, medical maggot. We're back to the old days. We're using traditional medicine in certain ways, but the raised in special forms. You put that worms on the wound of the patient, they will do the surgeon job. However, it's slower and more dirty. Very important to know, it's not debridement once per 1 week or once per month. I always tell the resident and anyone with me, you have to do multiple debridements, more than 2 debridements in a week, maybe 3 debridements. You can see here, multiple debridements, healing, time to heal is fast in comparison with 2 times or less than 2 times. So multiple frequent debridements. For managing the exudate, then after debridement, we need to do a selection of the dressing. Which dressing to be used? A common question every day people ask. It depends on the location of your wound. How deep is the wound? How much is exudating? If it's too much wet, you have to take something to absorb it to keep it dry. If it's less wet, you can use other modalities or you can space your dressing times. What are the tissues available? How is the situation of the peri-wound skin? If there is a maceration, then you have to use certain dressings also. Is it compatible with other things? You're doing gyps, you're putting contact cast. Is it compatible? And what is the risk of infection and avoiding of the pain? And what's the quality of the life of the patient if he can come to you or he cannot come to you? So I made for you this table. It just simply tell you the category of the dressing with the photos, examples of the brands, and from which company are there. Basically, I use the hydrogel if I have a dry wound, you want to wet it. If you have exposed bone, if you have exposed tendon, hydrogel is a very good choice. Hydrocolloid, we use it for the skin around the ulcer if there is too much exudate and it's macerated. So we can use it to prevent, because maceration causes infection. A silver dressing, you can use it for like a 2 weeks period only if you have a high risk of infection. Alginate, I love alginate in diabetic foot, either with silver or without silver. Alginate has the capacity of absorption and hemostasis. So if your patient has a moderately discharging wound, you can put for him the alginate, then you can space his dressing. Instead of doing daily dressing, you can do it every other day. Foam dressing is very amazing. There is a special foam for the heel with the adhesion. It's very nice. Patient can have a bath on top of it. However, you can use it if you have mild to moderate exudate. It can be changed every 2 to 3 days. Fiber dressing, they have the ability to absorb the exudate. If you have too much exudating wound, you can use it either as primary dressing or secondary. And there is other granulation stimulating advanced dressings available. As I said, all the papers, all the studies, all the experts recommend that you have to monitor. And our basically period is to monitor is 4 weeks. You have to see if the patient has 50% or more reduction in the size of the ulcer, then your management is working well. If there is no 50% reduction, that means you have something wrong. You have to go back again with all your steps, looking for what you missed, looking for what you did wrong, either in the examination or in the dressing time. What are the common organisms infecting? Well, it depends. Each hospital has, each country has different, each hospital has different. However, for exam purposes, it's around of most probably the Staph aureus, either methicillin sensitive or methicillin resistance. It's a gram-negative bacilli like the Klebsiella, Pseudomonas. We have a lot in our GCC country, E. coli, and don't forget the anaerobe bacteria. And as we said, we can specify the infection classification into grades, and accordingly, we have universal way of interaction with other centers and other hospitals. Which antibiotic? It's according to your hospital policy, but according to the organism, which antibiotic you can use. This is the soft tissue infection. What about the bone infection in diabetic foot when you have a deep ulcer causing osteomyelitis? 20% of diabetic foot ulcers, patients have osteomyelitis. Why we need to diagnose or prevent osteomyelitis? Because it carries more morbidity, it increases the healthcare cost, and increases the risk of requiring a major amputation. So it's the most common infection. It accounts in the mild ulcer infection, it counts for up to 15%. However, if a patient has a severe infection with cellulitis and sepsis, it's up to 50% chances of having osteomyelitis underlying your ulcer. What are the risk factors? We said the wound that extending to the bone or the joint. If the patient has a previous history of osteomyelitis, if the patient has recurrent or multiple wounds. How does the bone get infected? Well, mostly contagious from the soft tissue from the ulcer. It penetrates in, and the first layer affected is the periosteum. So you will have the peritonitis, and then you will have the cortical bone involvement. Hematogenous osteomyelitis is a very limited role in the diabetic. When I do suspect I have an ulcer that doesn't heal after 6 weeks of appropriate treatment, and you did also a flooding, then you're suspected. How will you diagnose? I said for you in examination. If you put a motile forceps, you probe it, you feel the bone, that means there is a high chance of osteomyelitis. Plain X-ray, it's delayed, you need time to see it. There's different bone scans. MRI is very helpful. However, exam question, the gold standard is a bone biopsy. You take a bone biopsy, you send it for culture, microbiology, and histopathology to know is it acute or chronic osteomyelitis. This is the probing. I probe bone. I probe through and through. This is X-ray. You can see here the proximal fourth phalanx is infected, is osteomyelitic, and here also you can see the head destructed, the head of the metatarsal. MRI show you some changes. We're not radiologists, however, we know. The pathogens will be the same as because you said it's coming from the ulcer itself, so it's going to be the same. Treatment, there's a big controversy between surgeons and endocrinologists and microbiologists, whether medical treatment alone is enough in osteomyelitis or whether surgical infection. The expert in osteomyelitis, my colleague, my friend Khafir, currently accepted that we need a combination of both. We have to remove the bone and antibiotics. But how we do that? If you remove, we have to remove most of the bone. If you remove most of the bone, then you will have a short duration of antibiotics, 2 to 4 weeks. However, if you don't remove the whole bone, then you have to give the patient longer periods of antibiotics, up to 12 weeks or more. So what shall we give, oral or IV? Well, I think everybody will say IV. Surprisingly, very recent study showed there is no difference between oral or IV groups and the antibiotics. This is just recently came by the UVIVA current control studies. So no difference. So the consensus on how to treat the osteomyelitis, you have to go and remove the total bone in certain cases. If the patient is systematic, having systematic signs of toxicity, if you have open or infected joint, if the patient has prosthetic heart valve, that's why I say holistic patient. If you have a clinical radiological proof of the osteomyelitis, or if you can see exposed trabecular bone, you have to go and do it. What you do, very important to know this information. First, you have to deal with the soft tissue infection, and then intervally after 3 to 7 days, you deal with the bone infection. Any bone dissection should be done by the power saw. No bone nippler, no bone cutting, please. So power saw to remove. This is the recent guidelines. We have certain other technology that can help us, such as the negative pressure with the installation system. Basically, it helps you if you have remaining your bone extend. You have to debride the bone until you have fresh bleeding bone. But if you couldn't do it, then you can have the help of the advanced system. This is a special type of a back dressing. It has two ports. One is to install the fluid, whatever fluid you want. You want saline, hypertonic saline, you want 1% acetic acid. It will keep it for time, selected time you put in the program, 10 minutes, 15 minutes, and then the other port is for suction. Can show you one clinical examination that we had. This patient at day 0, we applied after 3 days only, one application. After 1 week, you can see the difference. So we're able to make the wound ready for coverage in only 1 week of using this. There is more advanced sponge dressings for the same machine. It's called Cleanse Choice. We were the first people to have it in the Middle East, and we also reported our experience. And you can see what's the use of this sponge. It can do the debridement for you. For patients who cannot go frequently to the OT, like this patient, he has MI, he has a lot of problems. So we're able to do with 2 applications to prepare his wound without going to the OT. Another example, same thing, and patient became ready for grafting in 10 days. And this is after 1 month. Very important, whatever you did surgery, you didn't do surgery, is offloading, is the first line of treatment for ulcers in the sole. There is several types, but the gold standard is the total contact cast. And there is the other ones, either the traditional heavy gyps one or the fiberglass light one. And this is the air boots. We have difficulties with the patient because they have difficulties to how much they inflate the balloon inside. Or you can use the felted layers. You have to put 3 layers just to offload that ulcer from the pressure. You keep the wound away from the weight pressure. The big barrier is patient non-compliance. We have this problem. So we have to talk the patient, we have to convince the patient, we have to educate the patient and the family. Some patients have persistent deformity. We need to do the offloading by surgeries. And usually we have to change the structure after the biomechanics of the foot is changed. And we have to do it either by lengthening of the Achilles tendon, or by resection of metatarsal head, or by other form of osteotomies or tendon transfer. One simple example, this was having a bending, so prophylactic, we can see the head of the second metatarsal. You go and they did for him minimal invasive lengthening of the Achilles tendon, and you can see his pressure before the lengthening and after the lengthening. So this is a prevention. You prevent the patient from having an ulcer. Another complication of diabetic foot, and very important and very serious, very difficult to treat, and we suffer a lot of these cases, are the Charcot foot, Charcot arthropathy. It's a progressive, non-infective, destructive disease of the bone and joint. It happens in diabetes, it happens in other neurological diseases and renal dialysis. The incidence about 0.1. However, if the patient diabetic with neuropathy, the prevalence is up to 35%. There are certain theories, 2 major theories, German theory and French theory, on how Charcot foots are happening. The German theory is about the cumulative repetitive trauma with insensate joint causes the destruction, and the picture. The autonomic neuropathy is the autonomic dysfunction, will cause increased blood flow via AV shunting and causes bone resorption and ligament weakening. Recent theories responsible of the tumor necrosis factor alpha interleukin 1 by doing releasing osteoclast and osteoclast activity. Types who have acute and chronic. Acute is just like a picture of osteomyelitis or septic joint, red, hot, swollen with pain. The chronic has deformities, rocker bottom, I will show you now. And then you have certain radiological pictures. So this is acutely inflamed. You will think this patient has abscess, osteomyelitis, however, it's just a Charcot, acute Charcot. This is the chronic, this is the rocker bottom deformity, this is the X-ray showing the rocker bottom deformity, this is the end stage. And there is several radiological classification for the distribution. However, you need to know that most of the Charcot joint occur in these areas, mid and hand foot and the ankle joint. How to differentiate it? Well, basically, you need MRI, PET scans, and sometimes bone scan to differentiate. There is 2 types of treatment. Unfortunately, surgical treatment is much better. However, everybody is afraid because of high complication rate, and we suffer to find an orthopedic who will chance it and go and do osteotomy or do arthrodesis or do fixation either internally with the plates or with the external fixator or screws. Basically, we suffer a lot in the whole Gulf country. We have the same problem. So we do offloading, but the offloading should be for a long time, 4 months, 6 months. And then you can put the patient non-weight bearing while wheelchair or walker. And there is some medication not very effective. Yes, we can put external fixator in cases of Charcot foot just to control and allow the healing, and this is internal by screws. What are the complications of Charcot foot? Again, if you don't treat, ulceration, deep infection, osteomyelitis, uncontrolled deformity, and unfortunately, the end result that we don't want. We don't want to have the foot in the bucket. We need the foot to be attached to the diabetic patient, please. So basically, if we just tell the spectrum of therapy, if we had a diabetic foot, then with gold standard care of the advanced dressing, offloading, local wound management, debridement, infection control, vascular supply to that area, we can have spontaneous healing, and we can use other newer modality to help us. Either we said negative function, I'll tell you about growth factor, and there is the hyperbaric, I'll tell you now about it. And if this is the hyperbaric chamber in our hospital, we have 2. It's basically the patient goes into a large chamber with 100% oxygen. The therapy takes 1 to 2 hours. Each session needs 30 to 40 treatments. They say it's by increasing oxygen delivery to tissues, promote angiogenesis, antioxidant pathways. However, if you see the recommendation of the Undersea Hyperbaric Medical Society, diabetic foot is not there. Osteomyelitis, yes, but diabetic foot, no. And there is poor evidence of using hyperbaric for all diabetic patients. There are only case series, non-randomized trials, not very strong. Limitation because it's very expensive, not all insurance cover it, not available everywhere. It takes time, believe it or not. You need 2 hours, 30 times, 60 hours in the chamber, and it has side effects. Barotrauma, claustrophobia, seizures, even pneumothorax. So what are the cases from my experience, from the experience of the other people everywhere? We do put patients, if they have the one I told you, when we do the transcutaneous oxygen, less than 40, then they are good indication to try using the hyperbaric. Once they are 40 or above, then you will wean them off these hyperbaric treatment. We said, we did all of that, but still, there is an ulcer. The ulcer is not healing. It's a big ulcer, difficult ulcer. This is the role of plastic surgeon coming here, and we hope we don't reach to the last one. So as you said, surgical debridement will leave big defects. And then even with your standard care, you have maybe 20 to 30% failure rate if you do the flaps. And unfortunately, if you finish all your options with the reconstruction and then you have exposed bone and these things, then you have to end up with the amputation. Basically, we have the saying life versus limb. If the situation reaches to the life of the patient, then amputation is a must. However, we have to salvage the foot the maximum we can. So when we reconstruct the diabetic foot, we have to have a certain condition to have a successful long-lasting. So it should be long-lasting, it should preserve the gait and walking, it should be suitable for the patient, and it will be a fitting to his insole, his shoes, he can walk in it. So for successful salvage, I always ask to have the infection is controlled, debridement is done correctly either, and the blood supply, vascular supply should be there. And then we have to correct if we need the tendons and bones by doing surgical offloading. And then it's our duty as plastic surgeon to do the soft tissue reconstruction. When is the wound is ready to close? When you consult me, I see the wound. When there is no surrounding erythema, when there is a minimal induration, when there is no pain, you have skin wricklings at the edges, that means the edema is resolved, you have fresh granulation, and you have the new epithelialization coming from the edges of the wound, This is the wound ready to be covered. And you have to know, in diabetic, 90% we cover it with the simplest techniques ever. Only 10% of those cases that needs complex flap reconstruction. This is the reconstructive letter that you need. We can go from down to up, from simple primary closure to free flap. I'll just show you examples, pictures. You can do primary closure, why not? Even you as surgeon, if you have bone, you can resect the excess bone and then you can close it without any tension. However, you have to have two sets of instruments. One, you use it for the debridement, and the other one, new gloves, new instrument, you use it for the washing the wound for the closure. There is a good chance of delayed primary closure when you wait for the edema to subside, and then you can close it with the vertical mattress sutures, or you can use the help of the new technology. You can do like these technologies that you can do it every day. You can approximate more and more of the wound and close it delayed primary closure. Secondary intention we can use by the help of the advanced dressing growth factors, the hyperbaric, negative section like this one, using negative section, closing the wound, the ulcer. And this is using advanced modality of dressings. We are able to close it in only 2 months. This is using different types of dressing until we close it without doing any surgical procedure. Simple split thickness skin graft. We usually do the split, very thin skin graft because it's easier take, better survival, and we can use it only for the areas with granulation. I cannot put a graft on a bone or on an exposed tendon. And we can use the negative suction after putting the graft on top of it. It's very important. You have to shave the superficial granulation layer before applying the graft in diabetic foot because it's going to be colonized by organisms. And then it showed the literature that it's successful up to 80% of the cases in closing the wounds in early. This is examples of patient doing skin graft. One may ask, how did you put skin graft on a weight-bearing plantar surface? I said, no, this is non-weight-bearing area. Usually these are the weight-bearing, so we can put skin graft successfully, simple procedure, less than half an hour, and we were able to close these wounds. And it was by Dr. Sarah Al-Yuhas. He explained for you on Sunday the complication of the skin grafts and the other details of the different types of skin grafts. We can use dermal substitute. Basically, I did this simple drawing for you, whether it's acellular or cellular. Basically, we deal more with the acellular type, either a single layers, one procedure metroderm. We don't have very good experience in metroderm as we have a lot of infection and loss of the skin graft. We have a great experience in using Integra. It's very amazing, and we published that recently. We had 12 cases of a difficult, bad wounds with bone exposure, joint exposure, and we have a very nice engraftment rate of the Integra, 95%, and then the skin graft at second stage, 93%, with no cases of amputation or recurrent ulcer, and we were able to achieve all the wounds closed within 12 weeks. This is a very bad case of a patient who had abscess, and you can see how ugly the wound, tendons are dry, open joint. We successfully cover it with the Integra, and then with a skin graft, and this is the picture. Now patient 5 years, you can see how the difference, 5 years from the procedure and no recurrent ulcer, and he's still having his limb. Another deep wound extending using of the Integra skin graft, and we are saved. Another one, the same thing, amputation stump, transmetatarsal amputation stump. Flaps, Dr. Sarah Al-Yuhas spoke a lot about the flaps. When we use flap, when we cannot put graft, we have exposed deep filling defect, and the areas where weight bearing, we said the sole, we can use, and it's very useful in diabetic, delayed flap principle, that I do the dissection of the flap, I suture it again in the same place. After 1 week, I'll come back to turn it to the area that I want. This gives the chance of opening choke of vessels, increase the blood supply by vasodilatation, either by local sympathectomy or because of the hypoxia that happens. And usually you have to raise the flap. Some of the techniques below the subdermal plexus, we use without any tension, setting with 4-0 or smaller. Types of the flap, Dr. Sarah spoke with you, very important. We have the ratio of the flap in diabetic foot is 1:1, not the usual 1:2 or 1:3, because they have impaired blood supply. And then according to the location, you have different type of flaps. I can show you only pictures of like VY advancement to cover a flap, rotation of flap, either at the same time we do a rotation after debridement and close it, or we can use a delay. I did the raising of the flap, I suture it, after 1 week I turn it, and then no recurrent ulcer. We can do transposition graft. So what's the use? You put a graft, there is no weight-bearing area, we put the flap in the weight-bearing area. Other different type, double Z plus, rhomboid. Very important, this you can do also as a general surgeon, the 2 fillet flap, that you can excise the infected bone and use the skin from the palmar surface and invert it. Same like here, you can remove the bone and use the skin, the healthy skin, to cover the dorsal defect. Another type of medial plantar artery flap, reverse flow sural flap, and new techniques of propeller perforator flap that we depend on the small perforator of the skin. We don't violate big vessels, and these are a few examples of, we do peroneal artery propeller flap a lot, and this is the posterior tibial artery. You can see you cover the ulcers. Complication mentioned before, we have either excessive tension and we have gapping of the flap. We can have ischemia, venous ischemia, or even arterial ischemia necrosis. It happens a lot with the diabetic patient. The last part, we're going to talk a little bit about the microsurgery. Traditionally, everybody was afraid from using microsurgery in diabetic foot because of the relative contraindication and traditional understanding that diabetic patients have increased incidence of small vessel disease, so it'll give you foot ulcer. However, the studies showed that it's increased arterial occlusive disease or endothelial perforation is the main cause for diabetic foot. So we can use, however, free flap in diabetic foot have the highest failure rate, unlike if we're doing trauma or reconstruction. Because we do the anastomosis at the zone of the injury, we're dealing with elderly, sclerosed vessels, more difficult. So if we go for a case to do a free flap in diabetic foot, we have 2 things to see. We see that arterial segment I'm going to do the anastomosis on is there's no calcification, and there is pulsatile flow in that. If we don't have these 2 criteria, then we abort the procedure and we set the patient for amputation. Super microsurgery, there is super microsurgery in diabetic foot, yes. We deal with the perforated free flap of less than 0.8 mm, such as in this case. And if patient who doesn't have any major vessels or single vessel, or he doesn't have any branches, we go to use these small perforator to perforator using the sutures. And this is the suture what we use, the 10-0, 9-0 in comparison with the hair, human hair. So they're very small, we use it under microscope power. The perforator to perforator, we use the perforator from the muscles. Usually they're spared in the diabetic patient, and we attach it to the donor from another area with their perforator to cover the wound. Advantage, you will have more chances to do anastomosis. In diabetic foot, we don't violate any major vessels, we preserve the still flow, so there's no steal phenomena, and we have similar success rates. This is the big study of cases, 95 cases done in Asan Medical Center, where I was doing my fellowship, with a long follow-up to do for the flaps. Multiple different flaps were used. They have 90% of flap survival, and they were able to save 93% of the limbs, no amputation. And they did correlation why they have 16 cases of flap loss. It was related to the patient previous amputation or very bad peripheral artery disease. However, they found that chronic renal failure is not a contraindication as we thought before. Different types of free flaps we can use. The ALT flap, and this is, you can take it from the thigh to cover with a nice coverage. Another case, skip flaps, you can take and cover the bone, exposed bone. Another case of skip flap, we can use radial forearm also to cover defects, latissimus dorsi, muscle flap, as this case with the extensive debridement, and then used with the mesh to skin graft. Does reconstruction using free flaps in diabetic increase the 5-year survival rate? What's the result? What's the connection? Well, it was found from 121 cases that when they did the Kaplan-Miller survival estimate, they found that the 5-year survival for patients who underwent free flap reconstruction of their diabetic foot was 86, in comparison with 41% for patients who had above knee amputation and did not have the free flap. So yes, the free flap of the diabetic foot can increase the survival of the patients. The complication of free flap is as much as the complication of any flap. We can have arterial occlusion, infection diseases, venous congestion, and this is our other friend worm. We love dealing with worms. Leech, it's green. When it sucks the blood of the venous, it does the venous drainage, it becomes swollen, become black and die. So she drinks blood till death. This is one of our cases. It has a superficial gangrene. Only the skin is affected. The deeper tissue are covered, and we're able to save the foot by putting metroderm and skin graft. So basically, to summarize the management, when we have diabetic foot defects with infection, always we have to evaluate the patient, as we said, as a whole, and then we see the vascular status of the patient. If it has vascular problems, we refer him to a vascular surgeon. Either he will do angioplasty with the angio, balloon or stents, or bypass surgery. If he failed, then we cannot do miracles. If there is no blood supply to the foot, amputation is the answer. We cannot plant anything in a dry desert. And then if it's blood supply is okay, then we do according to the wound. Simple wound, then we can do simple coverage, conservative treatment. If it's complex wound, we said we need to do reconstruction either by flaps or flaps. If we fail our options of reconstruction, then unfortunately amputation. Very important, after doing the surgery, we have to do rehab, we have to preserve the foot from not having another ulcer, and usually we have to deal with the good footwear, and we have to educate the patient and the family. We don't want to end up a patient like this. We also, if we need to do amputation, we rather have a minor amputation rather to have a major amputation. So amputation, diabetic foot, in cases that I explained, either minor to re-amputation transmetatarsal, or major that we wouldn't want to reach below knee, above knee, or hip articulation. And this is the levels of the major amputation. Minor amputation is the foot and below. What is the indication? As I told you before, the principle of life versus limb. Patient in septic shock, gangrene, wet gangrene, we have to do amputation to save the patient life. So systemic sepsis, if we have major loss, if the patient lost everything, you just have bone, there is no tendon, no ligament, no nerve, so it will be non-functioning limb. We will do amputation if the patient had severe comorbidity, if he's non-compliant, and if the no blood supply, the vascular fails to revascularize. The last part of the lecture, it's what's new in diabetic foot. Siren socks, smart washable socks that detect the injury, detect the change in temperature. It's very useful now in the pandemic of COVID-19. This is how it looks. It's connected to your phone and the physician phone, and then you can inspect if anything happens without the patient looking at his foot. EGF, epidermal growth factors, a lot of studies been on that. We had a lot of cases. It showed that they promote proliferation, migration, neutrophils, macrophage, new vessels, migration, and everything. And several studies showed that, meta-analysis, systemic reviews, that the use facilitate the healing process, and they accelerate also the healing of diabetic foot at 4 to 12 weeks only of treatment. If you have Wagner stage 1 to 2, then you have topical solutions. If you have a deeper Wagner 3, 4, 5, then you have to use injectable forms. This is the one, the sprayable EGF, and these are the cases after 10 weeks, complete closure of the wound. And this is one case that we use, a paramedic, that we were able to close his wound in 2 weeks only from the EGF, epidermal growth factor. This is the first result, and we do use a lot of dressings. Lastly, the adipose-derived stem cells. It's stem cells derived from the fat, and then you can have the principle of the growth factors in the fat, and then the new vessel formation from the stem cells, and also it inhibits the production of the cytokines and stimulate the production of anti-inflammatory cytokines. A very famous procedure, DELT procedure, you do debridement with autologous fat, you do liposuction, you put in the tube, and then you inject at the periphery of the wound, you cover with a non-adherent dressing, and then you have a nice result, wound closure after 12 weeks with the help of the fat injection. Also, the fat can be used to graft either in the sole or for the tendon to make it softer. And this is a case, that case was injected for the fat in the sole, and you can see the ulcer is healed. Very important is to raise the awareness of diabetic foot, to encourage our patient for lifestyle changes, to let them practice more exercise rather than letting the dog on the treadmill or walking the dog. And if you're going to a gym, use the stairs instead of using the electrical ladders. It's not only educating the patient and educating the relatives of the patient. We do live hands-on courses, me as a part of Gulf Diabetic Foot Working Group, for all the doctors and nurses from everywhere, to help them how to diagnose, how to examine, how to treat and manage the foot. We do conferences and we meet with the experts either in the Gulf, internationally, in Asia, and everywhere. And believe me, it is all a teamwork. When me as a plastic surgeon, with a surgeon, with a podiatrist, with an orthopedic, with infection disease specialist, with a wound specialist nurse, everybody together works together to save a diabetic foot limb. And this is all the references that I used, and this is the lecture. This is the end of my lecture. I hope you understand it was long a little bit. I'm sorry for that. And it was non-stimulating much because of PowerPoint presentation.
Thank you, Dr. Nira, for the wonderful lecture. Now, as usual, we'll start with the post-session MCQ, and let's see how attentive our attendees were.
Yes. So the first question was again, which of the following is correct regarding diabetic foot ulcer in diabetic patients? Lifetime risk for developing diabetic foot ulcer is 50 to 70%. Recurrent rate for another diabetic foot ulcer in 5 years is up to 25%. Risk of some form of amputation is about 40%. There is no association was found between 5-year mortality and amputation in diabetic foot ulcer. Amputation in diabetic foot can be prevented in up to 85% of the cases. So let's see the answers and whether you can answer it much easier after the lecture or no.
We'll have another 20 seconds. Last few seconds. So we'll show the results.
Okay, very nice. Most of you got it correct, yes. Because lifetime is 25% and okay. So it is, the amputation can be prevented in 85% if you have good programs and good diagnosis and prevention.
On to the next question.
Next question. 75-year-old patient presented with plantar ulcer. He had exposure of the head of the first metatarsal bone with abscess collection. All of the following is correct, except most probably the etiology is ischemic ulcer. His correct Wagner classification is grade 3. University of Texas, PEDIS, and SIMBAD are additional classification systems can be used. Most probably the etiology is neuropathic. Offloading using either total contact casts or removable air boots is needed.
Seconds. And the time is up.
Cannot see. Again, good. 32% answered the correct answer. The wrong statement is the etiology ischemic ulcer. It is a neuropathic ulcer, and the Wagner classification is 3, and offloading is very important in this condition. Using any type is fine. So the correct answer is A.
Good. Now to the third question.
Yep. Third question. In regards to assessment of diabetic foot patient, which of the following is correct? The Simmons-Winston monofilament test should be done for all 8 sites to be able to identify 90% of patients with peripheral neuropathy. Transcutaneous oxygen is superior to ABI in predicting wound healing potential and the degree of small vessel disease. ABI of more than 1 exclude peripheral vascular disease in diabetic patient. Palpation of peripheral pulses has no role in assessment of vascular status in diabetic foot. Critical ischemia is diagnosed when ABI is less than 0.6. So which one is correct?
They will have 1 minute to answer the question. Thirty seconds left. Last few seconds. Time is up.
Again, 47% answered the correct question. Answer, yes. The first option is wrong. You need only 4 places to test to have 90%. Yes, transcutaneous oxygen is more superior. ABI more 1, no, doesn't exclude because you have medial calcinosis, so they have diabetic patient high ABI. And it's very important to palpate the pulses to assess the vascular status, critical ischemia whenever less than 0.4, not 0.6. So well done.
Perfect.
B is the answer.
So to the fourth question.
For the question, all of the following are considered a recommended type of wound debridement in diabetic foot except hydrosurgery, autolytic, biological, surgical, wet to dry. I bet everybody will answer this correct. Should be 100% correct answer.
Thirty seconds left. Last few seconds. And time is up.
Oh, okay. 59% or 60% got the right answer. I'm disappointed that not 100%, but anyway. So wet to dry is not recommended. All the other methods are well recommended to be used as a method of debridement in diabetic foot ulcers.
Not 100, but good enough.
Good enough. So I was expecting because I said. Okay, the last question. Yeah, 64-year-old patient with long-standing uncontrolled diabetes, hypertension, ischemic heart disease. He presented to your clinic with 4 months history of heel ulcer. On examination, there is 8 by 6 centimeter deep ulcer with necrotic slough. Probing test was negative. No evidence of cellulitis or collection, and both pulses were felt. What is your next step? CT angio is needed first before any action or debridement. Admission is needed with swab culture and startup IV antibiotics. Dressing and hyperbaric oxygen chamber to improve healing. Sharp debridement, regular frequent dressing with close follow-up of loading and vascular lab study to prepare him for wound coverage. Prepare him for a below knee amputation as heal, never heal.
We'll give them 1 minute to answer. Thirty seconds left. Last few seconds. Time is up.
So I'm very happy, 67% answered the correct answer. This I will explain a little bit. First, for the CT angio is needed, this patient has palpable pulses. So you don't question that there is any significant problem in his blood supply to the ulcer. So no, you don't need CT angio before doing any debridement. Admission with the swab cultures and startup antibiotics. There is no evidence of infection or abscess. One thing to explain, swab culture should be forbidden. No swab culture is indicated in any case of diabetic foot. They already, chronic wounds are colonized. If you are really concerned to have a culture of the organism so you can start the specific treatment according to the culture, you have to take tissue biopsy and send that tissue biopsy to the culture. So no more wound swab. Swab culture is big no, and you don't need to start IV antibiotics since there's no big chance of severe infection. Dressing and hyperbaric oxygen to improve the healing. As we said, he has necrosis, he has a slough. You have to do debridement of that slough. So yes, you have to do sharp debridement, frequent dressing, offloading as the heel, and then you prepare him vascular lab study to see if he has any peripheral vascular disease or no. And just for comment for the last one, heal, never heal. This is when I was a medical student. I don't want to let you how old I am. 20 years ago, 25 years ago, this was the saying. It's not anymore. Thanks to plastic surgeon, heal, yes, heal. We can heal the heel, we can cover the heel. So no one should say heal, never heal. It's a very old saying. It's not anymore, not applicable anymore.
Perfect. So we're done with the questions and
question and answers.
No, we
can.
Can.
One question: how do probe bone test? What is its significance? As we said, we want to see if there is osteomyelitis, if there is bone involvement. So we said higher risk of osteomyelitis if the bone is exposed. And deep ulcers, pointing ulcers, don't see the bone exposed, but there is a track going in. So as we said, osteomyelitis happens when you have soft tissue infection, the infection spread locally to the bone. So if you take a metal forceps or even a plastic forceps, if you put it in the ulcer, push it till the end, if you hear it's hitting the bone, that means it's a positive probing bone test. That means more than 50% chance of osteomyelitis. This is the significant, and this is how do you do. Regarding examination diabetic foot, when do we palpate the femoral artery and inguinal lymph node? And as we said, if you want the inguinal lymph node, if you have a suspicion of spreading infection, you palpate the inguinal lymph node. If it's involved, then there is a sign of a spreading infection and a diabetic foot soft tissue infection. Femoral artery, you palpate. What I teach you, the 3-minute examination is the fast examination. If you have high suspicion, you did the peripheral pulses, you don't feel the pulses, then you go higher up, you palpate for the popliteal. You don't feel the popliteal, you go higher up and palpate the femoral. So you want to know the extent of the peripheral vascular disease, and hence you would have to refer him to a vascular surgeon. Another question, what is enzymatic debridement and how does it work? Yeah, the same as I showed you. It's a certain kind of a cream having collagenase material. The collagenase will go and react with the necrotic tissue and it will dissolve it. So when you do the dressing next time, you will have all the dead tissue out from the wound. It's a slower way of doing debridement. As I said, the best to do with sharp debridement, surgical debridement, but sometimes if the patient is not in the hospital, he cannot come, he lives far away, you can give him to do this dressing and it will do a longer time of debridement and painless. The fastest one is the surgical debridement. Mechanism of surgical offloading. The mechanism of surgical offloading is if you have a deformed foot, already the patient has the head of metatarsal coming out, or he has a claw foot, this is permanent. Whatever you will do for him, you cannot put him on cast or air boot forever, because even if you heal the ulcer, once you will open his cast away, he will have recurrent ulcer because the cause is there. The head of bone is protruding, pushing against the floor. So you need to correct his biomechanic of his foot. So maybe you need to chop off that bone, even in the claw. You may need to cut just the osteotomy of the bones. They have shortening of the tendon archaeus. So if you long it, then they will have easy, the foot will go the same as a normal foot. The whole sole of the foot will touch the floor, not only the heel part. So this is, it's a more permanent way of offloading for patients with deformities, with recurrent cases of neuropathic ulcer, or sometimes you do it prophylactic before having an ulcer. You predict that having an ulcer. Why can't we put skin graft in weight-bearing areas? As we said, skin graft will be lost if you put it under two areas. If you have a bone of the head metatarsal and you have the sole, it's non-sensate, it's thin, with the friction, with the pressure, it will break easily. Imagine the foot itself break and happen an ulcer. Or what about a thin skin graft with no sensation? Definitely, we will have recurrent ulcer. That's why we don't put it in the pressure area, because it's useless. It's going to be lost once the patient walks on it. Okay. There's time, or the time is finished? How is the swab culture different from tissue culture biopsy? When you swab a wound, you will take the superficial secretion. Superficial organisms are always colonizing the chronic wounds, and diabetic foot is a chronic wound. Even if you take a swab on your skin, you will see multiple organisms. Organisms on the surface of the wound doesn't mean it's infected wound. And usually, why you need a culture? You need a culture to know which organism to give appropriate antibiotics. If you're not going to give antibiotics, so there is no use of doing wound swabs. If you are suspecting or you're suspecting infection, you need to know which organism, which antibiotic to use. You take the deeper tissues, take the whole tissue, and you see what's inside the tissue. And then you have a quantitative, the number of the colonies there, and you will have more sensitive result for if it's a wound infected or no. Swabs will give you only colonizing wounds, not infected.
We'll answer the last two questions as we're running over time.
How is swab culture different? I did. Will the radiofemoral delay be there in neuroischemic disease? Yeah, it might have, yes. It might have a combined of both, the loss of sensation and the decreased blood supply to the foot. And this most common type of the diabetic foot ulcers we're dealing with, they have the both pictures of both. And that's it.
Perfect. I think we're done with the Q&A. Thank you. Thank you, Dr. Amnira, for the wonderful lecture. It's been a pleasure to have you again on our Surgical Fix series. And sorry for the audience, they didn't get to see the wonderful slideshow you had as the first session. But hopefully you will be able to give us another session sometime later with the slideshow. Thank you again, Dr. Amnira. And thank you, the audience, for attending our session. Just a reminder, we have our next Surgical Fix. The link will be available in the chat, and our mock session too. If you can also take 5 minutes of your time to fill the survey to help us improve our courses. Thank you, Dr.
Thank you so
Amnira.
much, Dr. Ali. Thank you, everybody, for listening, and sorry for the long lecture.
Thank you. It's been a pleasure.
Pleasure is mine.
Everybody, this is the QR codes. As usual, you can open your phones and scan for the next session. You can scan also to take you to our platforms on Instagram, Twitter, and recap our previous lectures for the website where you can watch the previous videos, or you can listen to them on Spotify and podcast and Apple Podcasts. You are free to leave the session, or I will leave the QR codes up for a couple more minutes. And thank you again for attending.